This slide shows the right and middle hepatic veins coded in blue with flow toward the IVC where they converge. And this is a typical spectral Doppler tracing, in this case from the middle hepatic vein, showing the normal triphasic waveform. Monophasic waveforms, as in this case in the right hepatic vein, may be seen in a number of conditions, most notably cirrhosis, as in this case. The Budd-Chiari syndrome is something we get asked to look for fairly commonly as well. It's really an amalgam of diagnoses, and it results from hepatic vein obstruction at any level, from the IVC to the main hepatic veins to the small venules. The grayscale findings include enlargement of the liver, hypertrophy of the caudate lobe, inability to visualize the hepatic veins, which usually, unless the liver is very abnormal otherwise, are easy to see, and thickening of the hepatic vein walls or intraluminal clot or webs. In this case, the clot or webs would be the actual cause of the syndrome. On Doppler, we may see no or reversed flow in the hepatic veins or development of intrahepatic collaterals. Here's an example of a patient with Budd-Chiari syndrome showing a small bit of color in the hepatic veins, but you can see the path of the right hepatic vein in this case on the grayscale image, and there is no flow on it. And here, of course, attention to technique is very important. And this is for an older article from 1993 from our group at UCLA, where we looked at color Doppler in the Budd-Chiari syndrome, in this case showing development of collateral vessels on the left and the actual site of stenosis in the IVC as indicated by the arrow on the right. The hepatic arteries are most important to look at in transplants because unlike in the non-transplanted patient, where the portal venous system accounts for most of the flow, post-transplant the hepatic artery is extremely important. Anatomic variations such as a replaced main, right, or left branch are common, although we typically don't diagnose those sonographically. Normally, the arterial waveform is of a low resistance pattern, as is shown here in this normal hepatic artery. Shunts are also frequently seen, spontaneous, operative, or transhepatic. In the past, operative shunts as therapy for portal venous hypertension were fairly common. We don't see those so frequently anymore, and the main types of shunts we look at these days are transhepatic shunts, and I will concentrate on those. But here is an example, a rare example in the case of my institution, of an operative portocaval shunt. And it's a little bit easier if I label the vessels for you, here in this case the portal vein and the IVC, and there is the shunt. You can actually see the flow communication through from one vessel to the other in grayscale and then in color. But those shunts you have to look for really carefully. The communication site is often not very large and deep, so it can be somewhat difficult to see. The most frequent type of shunt we see these days are TIPS, transjugular intrahepatic portosystemic shunts. The most important take-home point in these is that angle correction, going back to what I said earlier, is critical. And I always do the angle correction using the grayscale, not the color Doppler image. You want the angle correction cursor to be parallel to the flow stream, and that's often easier to tell on the grayscale image, as I'll show you. It's also important to know that the shunt may not be seen in the first few days because of gas around the shunt, and that can shadow and completely obscure the shunt, so we tend not to do baseline sonograms early. It's important to measure the velocity at least 3 points in the shunt, the so-called portal vein terminus, mid-shunt, and the hepatic vein terminus. Thrombosis is indicated by lack of flow on Doppler imaging, whether color or spectral. Stenosis is more difficult to diagnose, and a variety of criteria have been published for this, including velocities less than 90 centimeters per second, or what I think is more important, a decrease from baseline. Here's an example of normal flow at the portal vein terminus of a shunt, and it illustrates the importance of angle correction using the grayscale image. I like to zoom up the image quite a bit so I can see the vessel wall of the shunt very clearly, and set the angle correction cursor that way. In this case, the velocity is 57 centimeters per second, but this was a normal shunt. It had not changed from baseline. That's why I think that a change from baseline can be a more important indicator of impending stenosis than just an absolute velocity. And here we see the flow velocity measured at the other end of the shunt. In this case, the operator has elected to do it with the color Doppler image, but you can see that the color Doppler makes it a little harder to tell where the walls of the shunt are, although in this case we're probably not too far off. This is a case of a thrombose shunt shown in this clip, and you can see there's no flow here. Remember that early on you may not see anything because of gas shadowing, but that's not true in this case. We can see the shunt, we just don't show the flow. And this is a thrombosed shunt. Here's another shunt with a stenosis with a velocity of almost 48 centimeters per second at the portal vein terminus, and this did represent a significant drop from the previous scan. And looking further distally in the shunt, in this case in the mid, the velocity increased to 2.4 meters per second, indicating a shunt stenosis. Here's another common site for shunt stenosis. This is where the shunt enters into the hepatic vein. You can see that as color Doppler aliasing. And here's the corresponding spectral Doppler tracing showing a high velocity of 2.7 meters per second. Post-transplant, the role of ultrasound is to detect vascular complications early so they can be corrected and not require explantation. As I mentioned, the hepatic artery is very important post-transplant. It assumes a predominant role in blood supply to the liver. Normally, it has a low resistance waveform with a resistive index of 0.55 to 0.80. But it's important to remember that high resistance flow is common in the early post-operative period. It is not abnormal. Complications include stenosis, thrombosis, and much less common pseudoaneurysms. Here's an example of an arterial tracing post-transplant, normal, and here's one post-transplant early in the post-operative period with essentially no diastolic flow. This is normal. Thrombosis is indicated by lack of flow in the proper hepatic artery or intrahepatic branches, whereas stenosis, which usually occurs at the anastomotic site, is associated with a focal elevation of velocity with turbulence, just like stenosis elsewhere. The problem is that the site of anastomosis is often difficult to see in these patients, particularly if they're in the ICU setting. So we rely on indirect signs quite a bit, such as a tardus parvus waveform in intrahepatic branches and a resistive index of less than 0.5, as indicated in this case. The main hepatic artery, this is almost a monophasic waveform with a resistive index of 0.32 in this patient with hepatic artery stenosis. It's also important to look at the portal and hepatic veins post-transplant. In the portal vein, looking for thrombus, stenosis, or aneurysm, and the hepatic veins in IVC to look for stenosis or thrombosis. But these complications are less common.